What are the 5 biggest myths surrounding hiatal hernia? The first one is you have to have surgery in order to really fix it. Number 2 is that you have to take a PPI, a proton pump inhibitor. That's an antacid medication. Number 3 is if you don't have acid reflux, you couldn't possibly have a hiatal hernia. The fourth is that in order to diagnose it, you have to have an endoscopy. That's the way to diagnose it properly. And last, if you have a hiatal hernia, it's really all because you're overweight. So those are the 5 biggest myths. Let's jump into each one of them so you can get really a full understanding, because I don't want you suffering with this and not knowing it and also not knowing your options. So number 1 is surgery. And basically what people are told is that surgery is the only way to sort of reconstruct your anatomy. And that is what surgery is doing. It's reconstructing your anatomy. It's changing it such that your stomach can't push up above your diaphragm, which is what a hiatal hernia is. Now, sometimes surgery is needed, but what's important to know, the statistics are that 23% of people who get surgery within a 5 to 10 year period need antacids all over again. So what is that telling you? It's telling you that the stomach is being squeezed and it's pushing up the acid into the esophagus, and the damage, and that's why people tend to do surgery, is prevent the damage that the acid causes, or somebody who can't get relief from PPI medication do the surgery. But a very common recurrence, almost a quarter of the time, is that people have to get back on the medication. Now, 50% of the time, people tend to suffer from symptoms like trouble swallowing, bloating. Of course, after the surgery, they let you know your likelihood of being able to even burp is impossible, let alone vomit. Now, nobody likes to vomit, but sometimes Mother Nature wants to do that. If you got toxified by a food, Mother Nature likes to get it quickly out of you so it doesn't have to permeate through your entire system. So you're not able to vomit after these surgeries, and burping is something that some people can't do, but they also have trouble swallowing and they have a lot of bloating. So that's very uncomfortable. And the symptoms that lead you into the problem are a lot of bloat and gas and pain. So these symptoms come back. And another side effect of surgeries is something called dumping syndrome. Now, it happens in 5 to 10% of individuals, and it occurs because the vagus nerve is either stretched or damaged. And the vagus nerve goes throughout your body, mostly to your digestive organs, but it also goes to your heart and your esophagus, and throughout the rest of your digestive tract, your stomach, your small intestine, etc. So it's a very, very critical nerve, and it can get damaged in the surgery because it passes down the same route from your mouth down to your stomach. It passes along that same route as your esophagus does, and that's where the surgery is taking place. Now, with a dumping syndrome, because the esophagus is damaged, what occurs is that your stomach and your small intestine can't hold on to food as long as it needs to. Now, your stomach should hold on to your food for 2 to 4 hours. It's a 2 to 4 hour process where your stomach acid is working on what you ate, so you can absorb key minerals like calcium and magnesium and zinc and vitamin B12. These are very, very key nutrients for long-term health. And with the dumping syndrome, things are moving too rapidly. So not only do you have diarrhea and you have pain, you have to be close to a bathroom, but because the food is passing through you so quickly, you're not absorbing your nutrients. So it's setting you up for a terrific problem of malabsorption and of course ill health due to that, and there's really nothing that can be done. And so these are, again, 5 to 10% of people. I've definitely heard from them, and it's a very miserable experience. So of course all surgery has its risks. That is one, but I'm bringing this up because there are alternatives for some people. Some people have a small sliding, by the way, 95% of them are sliding hiatal hernias. And if you think about that, the vast majority means small and also sliding. So what does sliding mean? It means the stomach pushes up above where it should be. That's a more than 2 centimeter movement. That's the definition of small. But then it goes back down. So if it can go back down, why can't it stay down? And that's really the focus that I have, and the clinic has, is getting to the source of why that pressure is there and pushing it up, because if it can go up and down, it can stay down. So something, just a perspective to have. Again, there are definitely times surgery is necessary, and you have to kind of bite the bullet and cross fingers and toes that you don't fall into the category of people who do poorly, and I appreciate that. But there's also a lot of individuals that for a small hiatal hernia are undergoing surgery because they think, well, this is the only way to fix it. And I think there are other ways as well. So let's go on to number 2, which is the use of the PPI medication. So these are proton pump inhibitors, and if you're suffering from classic heartburn, acid reflux, when you first get on these medications, typically they're wonderful because you feel so much better. That acid is not coming up, you're not having the burning, you're not having that terrible taste in your mouth, and you go, oh, this is great. Why is it, though, that the Food and Drug Administration only approves these drugs for 2 weeks of use? That's a very key aspect to look at. And a lot of people don't appreciate that minimal suggestion of just 2 weeks is there. And it's there for a very good reason. You have acid in your stomach because of 2 key reasons. The first one is that we do have microorganisms in our food, and it's not due to poor food hygiene on your part. It's just the fact that they are there naturally. But Mother Nature made their first destination. After you chew and swallow, it gets dumped in, your food gets dumped into a bag of hydrochloric acid called your stomach. And that acid is there because it kills these organisms. It's the first place they go, and they get annihilated because of a bag of hydrochloric acid. And that's how Mother Nature intended, and it's very protective of you. Needless to say, reason number 2, excuse me. The other reason we have acid, I mentioned that a moment ago, it's because that's how we absorb key minerals like calcium and magnesium and zinc and iron and vitamin B12. And when you don't have the acid present, you're not absorbing those nutrients. That's why the side effects of PPIs are many, including the infections for the reason I just mentioned, osteoporosis, brittle bones, because you're not absorbing the minerals I just mentioned, particularly calcium and magnesium, but also dementia and risk of stomach cancer, risk of heart attack and stroke, and also risk of your microbiome. If you're not familiar with that word, that's the 60 to 100 trillion microorganisms in your colon. The microbiome getting altered into a more inflammatory, bad bacteria state. Of course it would be, because there's no acid to kill the bad guys, so they happily procreate. So you're literally getting on a medication because your gut is imbalanced, and the side effect of the medication is an imbalanced gut. So that is why it's supposed to be sort of a very acute type of very short window of utilization of these medications and then get off. But instead, it has become quite accepted to continue to take them. So it's missing the root cause approach, and it's just band-aiding the symptom, but it's not looking at those side effects. And these are very well documented. I will have in the description of this video research to support everything I'm saying. So let's go on to, so you can see why that's a myth, why the surgery is a myth, if that's your only option. So let's get on to number 3, which is acid reflux. Now, it is typically true that people with hiatal hernia have acid reflux, also known as heartburn. And but as we get older, and that's the demographic that has more incidence of hiatal hernia. With every passing decade, you have that percentage chance of having a hiatal hernia. So if you're in your 50s, 50% chance, 60s, 60% chance, and so on. It's common, it doesn't make it normal to have it, but that is what's commonly seen. Yet, as we age beyond 40, we tend to make less stomach acid. So a lot of times we have very little stomach acid, But because of the pressure that's present, and this is really the root cause of hiatal hernia, the pressure that's squeezing the stomach, the little bit of acid that is there can still give you symptoms of the acid reflux and the heartburn. But there's also something else, and that's called silent reflux. And that can come about due to too little acid. And the symptoms are quite different, but you still have a hiatal hernia. You still have that aberrant pressure upon the stomach, pushing it up and creating the problem. But because maybe you're older and you have too little acid, or you just have the silent form of it, you've got more symptoms up in your throat. So you have a chronic cough. You maybe think it's allergies or you've been treated for an infection, but an antibiotic doesn't make any difference. You have hoarseness to your voice. Your singing voice has changed. People tend to notice. Sometimes pain into the ears and jaw, but it tends to be more upper because that's where the acid, as little bit of it as there is, kind of lodges in silent reflux. So it is reflux, but it's not manifesting in the classic form. The other key thing to note is that there is such a thing as bile reflux. Now, this tends to happen a bit more with people who have lost their gallbladder, but not exclusive to that. Now, bile is produced in your liver. It's stored in your gallbladder. When you eat a meal with some fat, the gallbladder senses that, it squeezes a bit of bile and it enters your small intestine, your upper small intestine. But if we've got this pressure problem again, the bile can be deflected upwards into the stomach. It should go into the small intestine and continue its way down, but it deflects and goes into the stomach and then also up into the esophagus, and you get bile reflux. Now, what's tricky about bile reflux is that bile is very alkaline. But alkaline is as caustic as acidic. So these are the opposite ends of the pH spectrum. But bile is just as irritating, if not more actually, to the esophagus. So you can have the same symptoms of burning and irritation, but it's bile. So it's definitely not going to respond to a proton pump inhibitor, which is decreasing your acid. So you really need to work with someone who can make this distinction for you between acid and bile. Now, you can have mixed, you can have acid and bile, but bile is often missed. So in this realm of acid reflux, what I want to bring about to your understanding is that 50% of the time, reflux is silent. So this is not an uncommon type of scenario that we're discussing. And it's silent due to not enough acid, or it can be bile, or it can just be moving slowly up the esophagus and it lodges up here, and you're getting more of those non-typical symptoms. And we say it's non-typical because we're just not used to dealing with it. It's not what's kind of approached traditionally medically, but 50% of the time, that's the culprit. So you can have non-classical acid reflux, meaning you don't feel it. You ask the patient, oh, do you have burning? Do you have heartburn? No, not at all. But they still have a hiatal hernia. That's why it's a myth. Okay, let's go on to number 4. Number 4 is that the only way to diagnose if you have a hiatal hernia is an endoscopy. And it is very commonly used. It's used, honestly, mostly because it's good at assessing the integrity of the tissues of the esophagus. So it can see if there's irritation to the esophagus, something called Barrett's esophagus, which happens over long-term acid reflux. There can be esophageal ulcers. So it's very good at determining that. It also goes down to the stomach and tell if you have gastritis, so inflammation of your stomach. It tests for H. pylori infections. It is not the gold standard to find H. pylori, so actually stool analysis where they use the PCR genetic testing is the gold standard. So a lot of times we meet patients who will find H. pylori on their stool and they say, wait, I had an endoscopy and they told me I didn't have H. pylori. So it's a different testing method, and the endoscopy is not as sensitive as it should be. Stool is 90%. Effective in identifying H. pylori. And that's important, but that's another discussion. What I want to get back to here is that endoscopy will miss hiatal hernia 40 plus percentage of the time. So it's almost a coin toss that, it's not quite 50%, it's approaching 50% depending on the studies that you look at, but it's quite close to that. So it's missing it too much. It's missing it too much of the time. So somebody who gets an endoscopy and says, oh, phew, I don't have a hiatal hernia, they couldn't find it. It's not accurate, okay? It's not accurate enough. Now there's other testing. There's manometry testing, which is a dynamic study of watching you swallow, and so if the sliding hiatal hernia is sliding up at the time, they can see that movement because it's not a snapshot. It's in motion. There's another test called impedance pH monitoring, and that's really great because it's pH. It's assessing whether acid is an issue or alkaline, right, or bile is an issue, and or mixed, as I mentioned earlier. But these tests are not typically done. A lot of times insurance won't pay for them. So what do? You look at your symptoms. You look at your health history. If you've had an endoscopy and it shows a lot of irritation in the esophagus due to acid potentially, it's kind of putting together pieces of the puzzle and building a case for hiatal hernia. There's not an absolute test that's going to show it, although the manometry is the best, but unfortunately infrequently used. So last but not least of our myths, we have weight. And people a lot of times write into my channel and say, I know it's my weight, I know it's that, I know that's the sole cause of my hiatal hernia, I just need to lose weight. So weight is a factor, absolutely. It's more the belly weight. So if you are somebody who has larger hips or buttocks, or you have more arm weight, that's not it. It is that belly abdomen weight, but it's not the below the skin weight. It's not what you can pinch. This is called visceral fat. So it's fat. The viscera are your organs. So the fat around your stomach, around your liver, around your colon, that's what's called the visceral fat. And that's the dangerous fat because it's very inflammatory, but it's also the fat that's creating pressure. It's that deep fat around your organs. Now there's certain tests that can show you if you have that. The reason I bring this up is that a lot of times if people are trying to lose weight, they're trying to lose that subcutaneous, that under the skin weight. Another factor here is what's called skinny fat. So you can be looking at somebody and you're like, they're not overweight, but they are over fat in the worst place possible, in their viscera. So they're not fat to look at. The scale doesn't say they're overweight, but they have that skinny fat. If you did a lean muscle mass versus fat percentage analysis on them, they have too much fat and they have it around their viscera. So it's not a simple look and see. You do want to handle the visceral fat, but that's all part of the protocol to handle hiatal hernia, which is to handle why the pressure is there, pushing on the stomach, forcing everything up, putting pressure on the diaphragm so it can't move freely, which then triggers shortness of breath, triggers anxiety because the nervous system starts sending out stress hormones because there's not enough oxygen coming in, and because of the pushing up of the stomach and the raising of the diaphragm, now the heart gets involved because you're getting in its way, and you start getting the heart palpitations, sometimes dizziness, lightheadedness. Now, certainly if you have heart palpitations, it's very critical that you first get your heart checked out. I'm speaking to those who have done that, been told their heart is fine, been told their lungs are fine, but they still have these symptoms. That's where we get into the realm of hiatal hernia syndrome. So we've talked about a lot here, but what I want you to know is that there are natural solutions for this. I did mention that sometimes surgery is needed. I'm sticking to that. But for a small sliding hiatal hernia, just think with the fact that it goes up and it comes back down. What we see is if it has that ability to slide, it can then stay down I mean, it only makes sense, right? It's getting pushed up and then, okay, then that pressure goes down and it goes down. Well, if you handle the pressure, does it make sense that it can stay down? That is what we see. So there are natural solutions to all of this. And the PPI medication, if you get on it for a short period of time while you're getting to the root cause of the problem, that's fine. But these side effects are very real, and I wanted you to know of them. So I hope this was helpful. There's a lot of help in this area, but unfortunately there are a lot of myths, and I wanted to really attack those because I hear them again and again and again. So I hope it was informative. If it was, or if you know somebody who is suffering with this or you think they are, please feel free to share this video with them. Like the video. If you liked it, please subscribe to the channel and write me a comment. I love your comments. I answer pretty much every single one I get. That's how I learn what you need and want to hear about. And we'll talk soon.